Today we're going to be talking about pseudoptosis. Pseudo, as you know, means false, and ptosis means it's drooping. So it's really important that we differentiate in ptosis whether we actually have true ptosis where the lid is down, or is it a pseudoptosis for some other cause. And so one of the things that we want to make sure is that it's not something wrong with the other eye. So the thing that can be wrong with the other eye is lid retraction. So if you have true lid retraction on the left, it might cause pseudoptosis on the right. And the way to figure this out is by raising this lid up with our hand. And if that's true lid retraction, it won't go down. If it's pseudo retraction, it will go down. And that's the Hering's law of equal innervation. In addition, the other side could be proptotic. So if the other eye is bulgy, or if the other eye has true lid retraction, you really should be thinking about thyroid eye disease or a mass lesion on the contralateral side, and that will make it appear like the right eye is enophthalmic, when in reality it's the left eye that is exophthalmic, and that causes a pseudoptosis in the ipsilateral eye. The other thing that can make the eye look ptotic is if the eye is up. So if the eye is up, that is a right hypertropia. So if the eye is up, it'll make it seem like the lid is down, but that is another cause of the pseudoptosis. The other thing you need to know is that it doesn't have to have anything to do with the levator at all in terms of its innervation. It could just be the muscle. So if something's in the levator, or if it's dermatochalasis, or it's a mechanical thing, it'll look like neurogenic ptosis, but really it's just extra skin, or there's something in the lid. And it could be spasm rather than paresis, which is orbicularis activation. So the orbicularis can be closing the eye, but that's not a paresis, and that's not really a ptosis, that's a pseudoptosis. And so patients who have cranial nerve 7 problems like blepharospasm or hemifacial spasm, or who have aberrancy of the 7th, where if they puff their lips out, the eye closes, those aren't really ptosis. Those are pseudoptosis because that's the wrong nerve. That's cranial nerve 7 rather than 3, or the Horner syndrome. So pseudoptosis versus real ptosis. Make sure it's real ptosis by excluding problems from the other eye, proptosis or exophthalmos. Make sure the eye isn't too high, hypertropia, or the eye is sunken in, enophthalmos. Make sure it's truly levator and not muscle or fat like dermatochalasis or spasm of the orbicularis causing pseudoptosis from closure of the lid.